Hello, my name is Dr. Jonathan Jones. I'm a rheumatologist at Samaritan Rheumatology. Thank you for joining me on this next lecture about crystal arthritis. I'm really excited to talk to you about this diagnosis today because crystal arthritis is very important to understand, and I think it's one of the easier rheumatic diseases to really grasp and be able to understand in a way that helps you feel confident. And I think that most primary care physicians should have a good understanding of gout and pseudo-gout, and with the right education and understanding are going to be able to manage most cases of gout on their own. So today what we're going to talk about is why do people get gout? What are the manifestations we look for and how do we diagnose it? And then we're going to talk about the different elements of treatment. And then we'll focus on pseudo-gout after that. So as we think about gout, this is very important because it's probably the most common inflammatory arthritis that is going to manifest. And it's common. You're going to see this often. So let's talk about what gout is. And the most important thing to know about gout is this comes because of too much uric acid. What is uric acid and why do we have it? Let's talk about that. Uric acid is ubiquitous within our body. We all have uric acid. It comes as a breakdown product of nucleic acids, and specifically purines. You can see from this diagram that as guanosine and adenosine are broken down, they come to a common denominator of xanthine, and then an enzyme called xanthine oxidase will break this down into uric acid. In humans, this is where the metabolism of purines ends. Interestingly, most other mammals and vertebrates will then have an enzyme called uricase, which will break the uric acid down into an inert substance called allantoin. And this has much less toxicity and is able to be excreted easily. Somewhere in the human evolution, we lost uricase. And so we stop at uric acid. If you would like an interesting trivia question, there's one other species that also lacks uricase and therefore can get gout. The answer? Dalmatians. As I mentioned before, the reason that people get gout is because of hyperuricemia. So how do we define hyperuricemia? This is defined based on the concentration of uric acid in the serum. So high uric acid is 6.8 milligrams per deciliter. Now, there are still going to be people who have uric acid levels above that level who do not get gout. So this is not necessarily a hard and fast cutoff, but it is an important number to keep in mind. And partly because this is the number that, in the right circumstance, the uric acid will be concentrated enough that it can start to form crystals. And it's when it's forming crystals that the problems begin. And therefore, if someone has too many gout crystals and we're able to lower the uric acid well below that threshold of 6.8 milligrams per deciliter, then they can't form crystals anymore. It's going to be dilute enough that that crystal formation stops. So remembering that 6.8 is helpful. Now, there was a time that we used to spend a lot of time as rheumatologists trying to decide if people with gout were under-excretors or overproducers. And in reality, it probably doesn't matter all that much. Basically, there's too much uric acid for whatever reason. It is probably helpful to know that renal insufficiency is going to be a common precursor to developing hyperuricemia, and therefore, for those who have kidney injury, they are more likely to have elevated uric acids. Most of the time, people with hyperuricemia either have acquired this because of kidney disease, or it's a genetic issue where their baseline levels just tend to be higher. Alcohol can contribute to hyperuricemia, especially beer, less so for wine. Many people often ask about diet, and diet can play a role. There can be small elevations in uric acid based on your diet. The reality is that major diet changes only change uric acid levels by about 1 milligram per deciliter, so usually not enough to make a huge impact on whether or not someone has gout. Medications can affect uric acid secretion, especially thiazide diuretics, and then we have to think about other causes like excessive cell death, such as in the context of tumor lysis syndrome. Now, one of the questions that will often show up on the boards is a patient will be presented and their uric acid level will be high, but the question is going to indicate that there's no sign of gout, but the uric acid is high, and the question is, should we treat the hyperuricemia? The answer currently is no. We don't treat hyperuricemia alone. It's got to be in the context of active gout. So that is a common board question. Please don't be fooled. Those who have hyperuricemia will very often go for years before they get any manifestations of gout. When they do start getting gout manifestations, it's going to be very important for us to recognize how that presents. Usually this is an acute, inflammatory, very painful arthritis. It's often a single joint. Sometimes it's 2 or 3 joints involved at once. Occasionally you get someone who presents with polyarthritis, meaning multiple joints all affected by gout at the same time. Those are less common, but they do happen. The classic presentation of gout is something called podagra. This is where the first MTP, the big toe, or the joint at the big toe, becomes very hot, very red, very swollen. And people describe this coming on in the middle of the night and is so severe that they can't even put sheets on their toe because it hurts so bad. This is the classic presentation, but it doesn't have to present that way. It could show up in the ankle. It could show up in a different part of the foot. It might even show up in the hand as a first presentation. But podagra is so common that is the most common way of presenting. When someone gets an acute flare of gout, it's interesting to think about how long that flare is going to last. For most people, gout is going to be very painful, present for 1 to 2 weeks. So an average of 10 days. Some people, it clears up faster than that. Occasionally it goes longer than 2 weeks, but the average is 1 to 2 weeks. It will clear on its own, even without any medication. This becomes very important if someone presents with right toe or left toe pain and swelling, and it goes on for 4 weeks, 5 weeks, 6 weeks. Could that still be gout? It could be, but you really want to start thinking about what else this could be. Is that swollen toe dactylitis because they have psoriatic arthritis? Is it something else, like maybe an infection, tuberculosis, or some other things. So that if it's going on more than 2 or 3 weeks, you really need to start thinking about another option for what this might be. The next question we think about is, if you have an acute flare of gout, when is the next flare going to happen? How common is that? For many people, they'll get their first flare of gout and they might not have another flare for 1 or 2 or 3 years. Some people get a first flare of gout and their next one comes a month later. So it does vary. But in the next slide, I'm going to show you a diagram of a common pattern of how the gout presents and changes over time. This is a common pattern of how the gout will change over time. You'll see that in the first stage, people will have hyperuricemia, but no evidence of gout. And that can go on for years and years. When they do start to get arthritis, it usually will be present for a short period of time and will vary on how frequently it occurs. Like I said, it could happen a few years apart, or maybe even a few months or weeks apart. But as the duration of the gout being present goes on, the frequency of attacks tends to happen more quickly, and there's less time between. When the patient gets to stage 3, now that gout becomes chronic, meaning that they don't have times without a flare. It's almost like the gout flares are stacked on top of each other. This usually means that the intensity of the flare may not be quite as strong as when they originally had the gout, but now it's just much more persistent and doesn't go away. When patients present in this stage, sometimes it's hard to distinguish them from rheumatoid arthritis or psoriatic arthritis or another chronic inflammatory arthritis. And that's why it's good to think about if this patient might have gout. Very often in these stages, you will be able to see tophi present on exam or possibly in imaging. The next few slides are pictures of what gout might look like. This is an image of someone who has podagra with the pain, redness, and swelling at the first MTP, and also has an ankle arthritis. So this is one classic presentation for gout. The next slides are going to be images of patients who have tophi, and you will see that the classic picture or view of these tophi is a pearly, almost luminescent whiteness under the skin. And it's often easy to recognize if you've seen it several times. Okay, so you have the patient in front of you. They have an acutely painful swollen joint. You look for evidence of tophi on exam. If you see tophi and you're confident that that's what it is, that's a confirmation that the diagnosis is gout. Many times, though, we can't see the tophi. They're not visible or evident. And so we have to think about, how are we going to diagnose this arthritis that we think is likely gout? There are a few options. One option is to check a uric acid level. Now, this is not always going to help in diagnosing the disease. If someone has a uric acid level that's super high, 11 or 12, then that very strongly increases the likelihood that their current arthritis is gout because it's so high. If the uric acid level is very low, 3, 4, it's really hard to get gout with very low uric acid levels. So that would make it less likely to be gout. But there's a pretty big window in the middle where it's hard to say. Part of the challenge here is that during an acute gout flare, the uric acid levels might drop and be lower than the actual baseline. So that's going to further add complications. So let's say that a person does have gout and their baseline uric acid is 8.5. You check their uric acid during the midst of a gout flare and it's now 6.5. Well, that's kind of below that threshold of 6.8, so you might think less likely to be gout, when in reality it could be. Alternatively, what if somebody has a uric acid level of 8.5, but they don't actually have gout? You might see that and think, oh, it's elevated, this is probably gout, when in reality it might actually not be there. So there's a big window where it's hard to interpret the uric acid level. One strategy is when the acute flare of this arthritis has resolved, repeat the uric acid. If it had been low or borderline before and then goes up quite a bit when the flare has resolved, then that is more evidence that it probably is gout. Another strategy you might do is to get an X-ray. X-rays are not usually helpful in acute gout, but for someone who's had recurrent flares, recurrent episodes, you're more likely to see bony changes on the X-ray that look consistent with gout. So early in the disease, not going to be helpful. But if it's a late manifestation or prolonged disease, you might actually see erosions that are characteristic for gout. Now, the best way, the ideal way to identify or confirm a diagnosis of gout is with a joint aspiration. So if you're able to stick a needle in the joint and get fluid and send that fluid to the lab for evaluation under a polarized microscope, that will help you see if crystals are present, what type of crystals, and will help confirm a diagnosis of gout. In the next slide, I will show you some images of what uric acid crystals look like under a polarized microscope. An important principle here is that uric acid crystals are negatively birefringent and are a javelin-like or needle-shaped crystal. Pseudogout or CPPD crystals are positively birefringent and are more rhomboid-shaped. Okay, so you have a patient in front of you who you either have confirmation of gout or you have a high suspicion of gout. Now the question becomes, what do we do to treat this disease? Now this is an area where it can get a little confusing if you forget the most important principles. And I will tell you that I have seen a lot of mishandling the treatment of gout because of what appears to be misunderstanding about what the medication is trying to do. For instance, I have seen some providers prescribe allopurinol to try and treat acute gout flares. Alternatively, I've also seen some patients be put on colchicine indefinitely as their treatment for gout. And both of these are not the best way or even appropriate ways to treat gout. So as we think about gout treatment, I want you to keep in mind that there are two goals. These goals are separate, and the medicines we use are targeted for each of those goals. So this is a very important principle. A good way to think about these two goals is treating acute gout versus chronic gout. Or a different way to think about that is to treat the inflammation that comes from the acute manifestation versus treating the hyperuricemia, which is part of the chronic gout. If you can keep those two goals separate and remember them both, then you're going to have a much easier time remembering how to treat gout. This is a good time to bring up the match analogy. An easy way to think about treating gout is to think of uric acid like matches. Now, in someone who has gout, the crystals, or the matches, are collecting in the joint over time, even over years. But most of the time, they're just sitting there, not causing any problem. However, something might happen, and that's going to light one or two or a few matches, and they're going to all light up together, and it becomes very hot, very painful, and can be really distressing. The important point then is, number one, can we treat the acute gout? Or in other words, can we put out the fire or treat the inflammation? And the second is, how do we get rid of the matches? This is an important principle because oftentimes we think about someone who has acute gout is because they suddenly get this big burst of crystals landing in their joint. But in reality, the crystals have been there for a really long time. They're just suddenly being recognized. Now the immune system says, hold on, what are these things doing here? They're not supposed to be here. So they treat those crystals almost like an infection, and that's what causes that acute inflammatory response. So first goal, treat the inflammation. Second goal, treat the hyperuricemia. Okay, so when we want to treat the fire or put down the inflammation, we typically use one of three classes of medications. The first one are the non-steroidal anti-inflammatories. These are very good at treating acute gout and usually are going to be first line, except for the fact that many of these patients have chronic kidney disease or maybe heart disease, so often we're limited. But for those who can take it, we often will start with NSAIDs. You can use any high-dose non-steroidal anti-inflammatory and get a good response. Oftentimes we use indomethacin because it's especially good at treating gout. But you can use ibuprofen, 600 to 800 milligrams 3 times a day. You can use naproxen, 500 milligrams twice a day. You can use meloxicam, 15 milligrams daily. You can use Celebrex, 200 milligrams twice a day. Pick whichever one you want. They're all going to be effective for most people. If NSAIDs are not an option, then we typically think about either colchicine or steroids. Both of these are effective. Colchicine is nice because there's less of a rebound effect like you might get with steroids, and you don't have quite as many side effects as you get with steroids. Colchicine is usually given as, or comes as a 0.6 milligram tablet. The treatment for acute gout is 2 tablets, or 1.2 milligrams, followed 1 hour later by 0.6 milligrams. If this does not stop the gout flare, you can repeat this the next day, and you could even repeat it a third day if you want. For me, if they don't have complete response after 2 days, I'll usually then switch them to 0.6 milligrams twice a day until the flare has resolved. The primary thing you have to watch for with colchicine is diarrhea. Steroids are very good at treating gout. And an important thing to remember is that it doesn't have to be systemic steroids. Sometimes a local steroid injection is the best way to treat gout. For instance, if you are seeing someone in the hospital who has an acute flare of gout in their knee, and let's say that they have recently been septic, and so you don't want to give systemic steroids, and they've got some renal insufficiency, so you can't give NSAIDs, And maybe they're NPO, you can't even give oral. In that situation, doing a steroid knee injection might be really beneficial for that patient. If you're going to use systemic steroids, this is one of those situations that breaks the rule that I will often reinforce to you, that 20 milligrams of prednisone is usually sufficient for most people with inflammatory arthritis. With gout, I'm going to amend that to say 40 milligrams. Usually I'll start 40 milligrams and then taper over approximately 10 days. One of the mistakes often made with gout is someone will have their patient take prednisone 40 milligrams for 4 or 5 days and then stop. And that leads to a high incidence of flaring of the gout after stopping. So one of the best reasons for a taper over about 10 days is that by keeping the steroid on longer, there's less of that chance for a rebound flare. Very often we will put someone on prophylactic medicine so that they're less likely to flare their gout. And colchicine is the best for that. In this situation, we'll usually have the patient take 0.6 milligrams once or twice a day for maybe 4 to 6 months while we're getting the uric acid levels down. If they haven't had any major flare-ups in that time frame, then we will stop the colchicine as prophylaxis. Let's now talk about the medications that get rid of the matches, or the ways that we treat hyperuricemia. The best medicine is allopurinol. This is going to appropriately lower the uric acid most of the time. Febuxostat is also a good option, although it's much more expensive than allopurinol. Usually we'll go to febuxostat if someone gets an allergy to allopurinol, such as a rash. Pegloticase is an intravenous medication that is essentially a uricase, so it breaks uric acid down very quickly and very efficiently. It's extremely expensive and has a high risk of anaphylaxis, so we very rarely use this. Probenecid is a very old medication that helps to lower uric acid by promoting uric acid excretion from the kidney. It is effective at lowering uric acid, but also comes with a high risk of kidney stones, which people do not like. So I don't very often use probenecid, although it is a good option if you become desperate. When I'm working with a patient, I will very often explain the match analogy because it's a little easier for patients to comprehend. And when I give them a prescription, I'll say, okay, this is for putting the fire out, or this prescription is to help lower the matches or lower the uric acid. And I'll often ask them to repeat, what's the purpose of the indomethacin? I want to hear them explain what it's for. What's the purpose of the allopurinol? I want to make sure they understand why they're taking it, so they're not just taking it blindly. An important point about putting out the fire. I like to use this analogy again because an easy concept for people to understand is that if a fire starts to build and you throw water on it quickly, you're going to have a much easier time putting it out than if you wait for it to get a lot of really hot coals and it's really spreading and growing lots of places. Now it's going to take a lot more water to put the fire out. This is going to be true for someone who has a gout flare. If they have a good agent that works to abort their flare, whether it's colchicine or an NSAID or prednisone, I make sure they have it with them. Put some in the glove box. If you're traveling, take some with you. Have a stash at work and a stash at home. And at the first sign of that gout starting to flare, hit it with that agent. The sooner you get on top of it, the more chance that you're going to stop the flare before it begins. And for many people who learn this technique and are able to do it, they might only have to take a single dose, and that will stop the flare before it gets too big. If you wait even an hour or two, now you might have to take that abortive agent for 2 or 3 days. I also want to talk to you a little bit about allopurinol dosing. So this is very important. The goal when we're lowering uric acid is to get that level well below the threshold for forming crystals. So for most patients, we're going to try and get the uric acid at least less than 6.0 milligrams per deciliter. For someone who has really aggressive gout, or maybe they have large tophi or erosions on exam, we're going to try harder to get it to even less than 5. So we're going to increase the allopurinol or febuzostat or whichever urate lowering medicine we're using until we reach that threshold. With allopurinol, the pills come as 100 or 300. For many people, we'll start at 100 milligrams a day, and we'll slowly increase that until we get to the uric acid threshold. Now, by slowly, I don't mean every month. I mean every 1 to 2 weeks, because we don't want to wait forever to get there, but we also don't want to do it too quickly. Part of the reason is that the most feared side effect of allopurinol is development of a hypersensitivity rash, which can be very severe, even to the point of toxic epidermal necrolysis or Stevens-Johnson syndrome. And we've found that if you start low with allopurinol and slowly move up, then the likelihood of developing a hypersensitivity rash is much lower. So for this reason, we don't start at 300 milligrams, even though we predict that someone might need 600. We're going to still start at 100 or maybe 150 milligrams and then move up as needed. For someone who has chronic kidney disease, you might even start at 50 milligrams. However, we're still going to push that dose as long as there's no rash development until we get the uric acid to goal. And we can push allopurinol all the way up to 800 milligrams a day. If we can't achieve urate lowering with that, it's either because they're not taking it, or maybe allopurinol just doesn't work for them. So then we try a different agent. Okay, so let's review how we're going to approach this patient. Your patient comes in, it looks like an acute flare of gout. Hopefully you already have diagnosed gout, or if this is a first time, you think about ordering a uric acid level, thinking about other possibilities. Could this be infectious? Is this part of a broader multi-organ process like rheumatoid arthritis? Can I aspirate the joint? Do I need to get x-rays? Will uric acid level be sufficient? Once you feel like you have a diagnosis of uric acid, once you feel like you have a diagnosis of gout, then you want to think about treatment. So we're going to, number one, treat the acute flare. We want to get the inflammation down. We talk about the different options with our patient and decide what we're going to try. If your patient already has tried something that works, go with it. If it's worked before, it should work again. We want our patient to know what agent they're going to use to abort their acute flares so that they can fall back on that in the future. If this is the very first flare of gout, I'm not usually going to start a urate lowering medicine at that time, because they might go for another 2, 3, 4 years before they have a gout flare again. If this has been a recurrent gout flare, or if they've had 2 or 3 in the last year, or if I see tophi present, then I'm going to start them on urate lowering therapy. So for most people, I'm going to start allopurinol 100 milligrams daily and plan to recheck the uric acid after they've completed their abortive agent and when they're not having any acute symptoms, but within the next 2 weeks, because I don't want to go for too long without checking. What I'm also going to do is think about prevention, because we know that one of the triggers for gout flares is when the uric acid level shifts. If we are actively lowering the uric acid by giving them something like allopurinol, that's going to increase the likelihood that they're going to have a gout flare. And what's that going to do? The patient's going to say, I'm worse with this medicine. I'm going to stop it. I'm never going to allopurinol because I had more gout flares. So you have to warn the patient, you're going to have more gout flares with this medicine. That actually means it's doing the job that we want it to do, because that means it's pulling those crystals out of the joint. As they're leaving the joint, they might become exposed. The immune system might recognize that and start the inflammatory reaction. So that's not unexpected, but we also want to anticipate it. In that case, we often will start someone on colchicine. So after they've completed their abortive agent, whether it's indomethacin or prednisone or colchicine, then I'm going to have them start taking colchicine along with the allopurinol. And for the colchicine, I might start once a day, or I might have them take it twice a day. Kind of depends on what their underlying kidney function is, the size of the individual, etc. After I check the uric acid in about 2 weeks, if that uric acid is still above 6.0, I'm going to go up on the dose. Now we're going to go to 200 milligrams, and we're going to repeat the uric acid 2 weeks after that. Still too high, now we go to 300. And we keep pushing the dose until we can get that uric acid to less than 6, or for those who have tophi, less than 5. And we'll usually continue the colchicine for anywhere from 3 to 6 months after we've reached the uric acid goal. And if they haven't had many flares, then we can stop the colchicine as prophylaxis. But patients often ask, well, how long do I need to continue the allopurinol? This is a lifetime medication. Unless you get a kidney transplant and suddenly can excrete your uric acid better, for most people, they're going to have continual problems with hyperuricemia if they stop the allopurinol. So it's just a matter of time before the gout comes back. So I tell my patients, the allopurinol is a lifelong drug. Okay, let's talk about pseudo-gout. The reason it's called pseudo-gout is because it looks very much like gout, and clinically it's going to manifest very similarly. A few differences are that pseudo-gout tends to happen in older patients. It often is associated with osteoarthritis, and it's more likely to occur in the larger joints. So for instance, if you have someone with crystal disease in the knee, it's probably more likely to be pseudo-gout, although it could be either. It's less common for pseudo-gout to affect the smaller joints, but still very possible. So how do we distinguish that from gout? Well, the best way, as I mentioned before, is by getting a joint aspiration and looking for those rhomboid-shaped, positively birefringent crystals. That's going to be confirmatory for pseudo-gout. It's not always possible to get the joint fluid, though. So there are other clues that you can think about. For instance, if it's associated with osteoarthritis, then you're going to think more about pseudo-gout. And x-rays in this situation can be very helpful. Specifically, what you want to look for on an x-ray is something called chondrocalcinosis. And in the next slide, I will show you some images of chondrocalcinosis at the knee and at the wrist. And basically what this refers to is calcification of the cartilage, which happens in the context of CPPD deposition. Now, to be clear, having chondrocalcinosis on x-ray does not automatically mean that someone has pseudo-gout. However, if you see it and the clinical picture fits with an acute inflammatory crystal disease, then the likelihood of pseudogout is much higher. When you make a diagnosis of pseudogout, I would encourage you to pause momentarily and just ask yourself, why does this person have pseudogout? We know that gout comes from hyperuricemia, and there are some secondary reasons for someone to have pseudogout. Now, the most common is either idiopathic or it's just part of the osteoarthritis picture. But there are 3 other diseases that you should think about because you would hate to miss them. And also, these are diseases that if treated, you might be able to reverse the pseudogout presentation. Number 1, hemochromatosis. Number 2, hyperparathyroidism. Number 3, hypomagnesemia. So if you are evaluating someone with pseudogout, check the ferritin, check the iron levels, check the PTH and the calcium level, and check a magnesium level. If you find that one of those is abnormal and treat it, the pseudogout might actually go away. This is really helpful because with the treatment of pseudogout, you remember the 2 principles we talked about with gout. Treat the inflammation, treat the hyperuricemia. With pseudogout, we don't have a treat hyperuricemia option. All we have is the option to treat the inflammation. What do we use to treat the inflammation of pseudogout? It's the same options that you use for treating gout. So NSAIDs, colchicine, steroids are the primary ways to treat pseudogout as well. If someone gets recurrent pseudogout, but they don't have hemochromatosis or hypomagnesemia or hyperparathyroidism, it becomes tricky because we don't really have any good agents that lead to remission of this disease. For many of those people, they end up staying on colchicine daily or a low-dose NSAID daily to try and prevent those flares from happening. So in that situation, pseudogout can be tricky to treat. Okay, there's one more crystal just to review briefly. This is not common, but it's important to know about. And this type of crystal is called hydroxyapatite crystal disease. This is another type of crystal that can cause a very inflammatory reaction. Most of the time, it will cause a tendinitis. Or if you see on X-ray calcific tendinitis, that's often from the hydroxyapatite crystal disease. Most of the time, this occurs in an overuse or repetitive use injury that leads to the development of these crystals, and then those crystals cause a very inflammatory reaction. Again, we treat it with NSAIDs, colchicine, or steroids. You might diagnose this because of an X-ray that shows calcific tendinitis, or you might presumptively diagnose this in someone who has a repetitive injury or tendon injury that just seems much more inflamed than you'd expect just from a simple overuse injury. This is not amenable to aspiration and looking for crystals under a microscope. For some reason, these crystals are very difficult to see and require special staining that most clinical labs don't have. So it's mostly diagnosed based on the finding of calcific tendinitis or a clinical picture that fits well. But again, we treat it the same way that we treat the acute inflammation of gout or pseudogout. Okay, that's it for the crystal disease lecture. I hope you found this interesting. I hope you found it easy to follow. I hope that you also keep in mind those important principles, especially the 2 goals when we're treating gout of treating the acute inflammation versus treating the hyperuricemia. If you can remember those and remember the medicines that target both of those goals, you're going to have a much easier time as you go forward and as you approach gout patients in the future. Hope you have a great day.